respected chairpersons and learned audience. My topic is questions are easy and answers are known, but what is the reality? So I choose this title from a popular song by Shumon, Kotota Pod Perole Tobe Pothik Bola Jay, Prosnogulo Sahoj ar Uttor Oto Jana. So let us find out the questions and answers and let us see the reality. My case, Mrs. Oy, 55 years hypertensive, non-diabetic, known case of chronic kidney disease patient, presented with shortness of breath for last 3 years. The symptom worsens for last 3 days, chest tightness and dizziness for last 2 days, she has history of syncope, 2 episodes for last 6 months. The patient was dyspneic and mildly anemic, her JBP raised, pulse is 40 beats per minute, blood pressure normal, and there is edema. On precordial examination, apex BT shifted laterally, and only there is a bilateral basal cavitation. And other systemic examination reveals ascites, enlarged tender liver. ECG shows 2:1 AV block, heart rate 37 beats per minute, QRS duration on 60 millisecond, and LBB morphology. TPM was done immediately. Her echo reveals LV cavity dilated, global hypokinesia, and LV systolic dysfunction, EF 35%. So the diagnosis is dilated cardiomyopathy with congestive heart failure, 2:1 AV block with OID QRS complex, and she had chronic kidney disease. So now see the questions. Could it be ischemic or non-ischemic? If ischemic, which one should be stabilized first, rhythm or reperfusion? What will be the appropriate investigation for this patient? Coronary angiogram, Holter monitoring, EP study. Let us see the angiogram. Our angiogram reveals, so it's not working. Anyway, her angiogram reveals normal coronary arteries. Anyway. So her angiogram reveals normal coronary arteries. So dilated cardiomyopathy patient with congestive heart failure, probably non-ischemic origin. So the questions now, what are the treatment options? CRT, ICD, permanent pacemaker. Let us see the guidelines. ESC 2020 on heart failure guidelines recommend if patients having heart failure with reduced ejection fraction, having high degree AV block, they are class 1 recommendation for CRT, regardless of the NOHA class and regardless of the QRS wideness. So now the answer is easy. The patient is indicated for CRT. But what is the reality? The patient could not afford CRT. So patient is on conventional guideline directed medical management. And now how will you fix the rhythm? Should we do a dual chamber pacing, RA and RB apical pacing, or RA and RB septal pacing? Or should we do RA pacing and his bundle pacing? Or should we do RA pacing and left bundle branch area pacing? Or should we do RA pacing and LB pacing? So just for understanding, the options are here. Apical pacing RB, and this is apical pacing, this is apical pacing, this is septal pacing, this is left bundle branch area pacing, and this is his bundle pacing. These two are technically very difficult. And this is the LV pacing through coronary sinus. So what are the evidences says? In the guideline, in this journal, they recommended that the alternative of CRT, in case of alternative of CRT, if RB apical pacing, RB septal pacing is not superior to RB apical pacing. This paper recommended in favor of RB septal pacing in alternate to CRT, that RB septal pacing is feasible and safe with more favorable clinical benefits than RB apical pacing. This article recommends that his bundle pacing and left bundle branch area pacing are more physiological method of pacing for conduction abnormalities in heart failure patients with AV block. This last two recommendation in favor of RA and LV pacing. They concluded that RA and LV pacing may be a cost-effective alternative to conventional CRT for patients in developing countries. So, Mr. Chairpersons, I would like to conclude here by some take-home messages. CRT is recommended in heart failure with reduced ejection fraction patients who have an indication of RV pacing due to high degree AV block. But if CRT is not affordable, then there are some options. His bundle pacing or left bundle branch area pacing are more physiological but technically difficult. RA and LV pacing through coronary sinus to mid-lateral LV might be good alternative. What about RV septal pacing? RV septal pacing have conflicting evidences, and RV apical pacing worsens heart failure. So thank you all for your patience hearing.